one. Sir, we are live now. Now we can start the session.
Thank you. Good evening, everybody, and welcome to today's evening webinar brought to you by the Orthopaedic Research and Education Foundation India through OrthoTV. Today, we have the pleasure of having Dr. Swarnendu Samanta from Kolkata, who's going to talk to us about clinical examination of the post-traumatic knee. And this was a webinar which was due a few weeks ago, but unfortunately, there were some technical problems that day and he could not do the presentation. So he has very kindly agreed to repeat it today. And so over to you, Swarnendu, for your presentation. Thank you.
Yes, sir. It's a great honor to be here again. And namaskar to John, sir, and all my seniors and juniors, those who have joined. I'm just sharing my screen. Janki, is it coming?
Yeah,
yes,
we
sir.
can. Yeah, but it needs to go on full screen.
No, I have already done the full screen.
No, it's not on full screen on the thing. Yeah, now it is. Yeah, perfect.
Now it is
now.
Okay.
Perfect.
Okay. So sorry, last time for the technical reason we could not make this out. But today we are going to present the how to examine a post-traumatic knee in a stepwise fashion, which is the clinical test that the master degree and the DNB student they must know. So I think like your all other examination around the shoulder or if you examine any orthopedic part of the joint, you have to have a detailed history. From the history or itself, you can make out some part of your diagnosis. So as we are going to discuss about the traumatic knee injuries, we have to take the history properly. What was the nature of the violence and what was the position of the knee at that time?
join karo,
And the direction of the violence is always also very important. And whether suppose it's a chronic knee, then whether there is patient is having any sort of crepitus or locking or giving way sensation, whether he is feeling comfortable or he is confident on his knee. This word, whether he is confident on his knee, this is very, very important history. And when the patient comes into the chamber or the clinic, you must first check the gait of the patient, how he is walking, but from to your side and how he is going back to and fro motion. Then where exactly, if he can point with his index finger, where he is getting the pain, where around the joint, and when it hurts him most. So this history taking is very important. Once the history taking is over, then you can probably diagnose some part, you can make a clinical diagnosis. Always remember that around the knee, we are going to examine the collaterals, the menisci, the cruciates, and also some important structure like your corner injuries, the posteromedial, the posterolateral, anterolateral, anteromedial, just the rotatory instability. And also because of the trauma, we might see sometimes the patellar instability also. So that from the history itself, you can diagnose. So like your any other joint, there is a protocol that we tell like look, feel, move, measure, and special test. Similarly, this holds good for your knee. Suppose when you're knee, first we have to take the history properly. So you take the history properly and you expose the patient and see the patient the uncovered like this way and take the patient's permission, and you check both the sides and you inspect from the top to bottom whether there is any swelling around the knee, whether there is any wasting, because the vastus medialis is the first muscle around the knee which goes into wasting. And always check whether there is any wound around the front of the tibia, because if you suspect there is a healed wound on the front of the tibia, that will tell you that there is a posterior thrust or the dashboard sort of injury. So that will give you the signal that you are not missing the posterior or the posterior cruciate injury. Now you see this is how you palpate. There is a classic way of doing it. See the tenderness on the bony points, like your medial epicondyle, see the joint line, see the base ancillary region, tibial tuberosity, then the patellar tendon, patella, the quadriceps tendon, whole insertion there, and on the lateral side, and also the proximal tibia. So this is the way that you classically test the bony points like your medial epicondyle, the joint line, the MCL insertion and the tibial side, the pes anceres region, the patellar tendon, the inferior pole, the patella, the quadriceps, then the lateral joint line. Also, you would see whether there is any tenderness on the backside or the along the hamstrings, because that will give you the you can see where is the tenderness the patient is having. Then we will test one by one the collaterals, the cruciates, and the menisci. Okay. The first test that we do for the collateral is the valgus stress test. So how it is done, you see? You see how I am holding the leg and where is my hand? Testing 0 degree of extension and also we testing 20 degree of flexion. When we testing 0 degree of extension with a valgus stress, that means this is the valgus stress test. We are testing the posterior medial corner. But when we flex it to 20 degree and we give a valgus force here. For the medials, I'm stopping here for a second that when we test the suppose the varus or the valgus test, remember that we test the varus and valgus both in 0 degree and 15 to 20 degree of flexion. When we extend, like when we test the varus or valgus in 0 degree of extension, we test the posterior structure. When we flex it to 15 to 20 degree, then we classically test the MCL or the fibular collateral ligament. Second injury, the medial collateral, we test in 0 degree of extension and also we test in 20 degree of flexion. When we test in 0 degree of extension with a valgus stress, that means this is the valgus stress test, we are testing the posterior medial corner. But when we flex it to 20 degree and we give a valgus force, we are classically testing the medial collateral ligament. Exactly opposite when we see, when we hold this and give a varus force at 0 degree, we test the fibular collateral ligament. Sorry. So the varus test, you see how we are doing. When we just do the reverse at 0 degree and we give a varus force, we test the posterolateral corner. But when we flex it to 20 degree and we give a varus force, test the lateral collateral ligament or the fibular collateral ligament. It is very. So remember, when we test the collaterals, it is done both in 0 and 20. So that when it is flexed to 15 to 20 degree, you classically test the collateral. When it is at 0 degree of extension, basically you test the posteromedial or posterolateral structures of the corners. And remember, sometimes the examiner asks you which is the classic and the most sensitive test of your meniscus. Always remember it is a joint line tenderness. You have to see the joint line from the back to the front, both on the medial and the lateral side, and you find that and you see the face of the patient, ask the patient where is the tenderness, because this is the most sensitive test for the meniscus. Then we do how you do the McMorris test for this way. For the medial side, remember, for the medial side, it is in extra rotation. And gradually from full flexion, we start gradually extending it with the extension. Then we see whether there is weakling or the patient is feeling any pain. So in extra rotation, if there is pain, at which point then remember that for the medial meniscus, you are basically externally rotating the foot or the leg. Extra rotating. Or for just the reverse, for the lateral meniscus, you will do the internal rotation. Whether there is any medial meniscal injury. More flexor means it is more to the posterior side. Middle means the middle part. Anterior is dubious. And the same thing if we do with the interrotation, from the full flexion to extension. Eastern rotation is for the lateral meniscus. Then we do like this. Then we can understand whether there is injury to the lateral meniscus. Stop. Then this is known as the apply grind test. The applicant grind test can be done in both. You can compress it like the axial load. You can compress the heel from the top side. It is at 90 degree of knee flexion. So basically, you external rotate. You see my hand how it is holding the heel. It is giving the axial load on the knee so that you rotate internally and externally. Then similarly with internal and external rotation, if there is tenderness on the medial side, with external rotation, you will be finding for the medial meniscal injury. And if it is done with the interrotation, then you will, this is known as the apply grind test. And this here, we give the axial load and external rotate and internal rotate. So in the external rotation, if there is patient is having pain, this is for the medial meniscus. And if we interrotate and patient complains of pain, then this is for the lateral meniscus. So we give the axial load, this for the meniscal. But the same apply grind test even can be tested with the distance along the upward force towards the rib. Then this with the external rotation and interrotation, this is tested for the collateral or the ligamentous injuries. So grind is basically the axial load, and when you distract it, you just test the collateral or the corner injuries. So this is known as the Thesele test. You see, this is not been asked to, but this is the patient will be standing on the injured leg, and he will be just dancing like on internal and external rotation. This is not been asked to, but sometime in the OSCE we can once it came. This is the way how you internal patient is just rotating internally and externally on the injured leg. If there is with the rotation, the external rotation, it is painful. It is for the medial meniscus, and if it is interrotation, it is just like the dancing. This is known as the Aegis test. How it is done, you see. Patient will be asked to squat for 3-4 times like this with external rotation. Similarly, the same thing can be done with the internal rotation. So this is the way you can see whether there is any meniscal injury. But classically, to test the medial meniscus or the lateral meniscus, remember the most sensitive thing is the history part, and also the clinically the joint line tenderness. Then we do the McPore. Then we do the apply grind test, and these two ancillary, the Thesele or the Aegis test, that can be done, or you may just see once, and if it come in the OSCE or in the picture is given, you can answer it. Then for the ACL injury, then from the collateral we come to the cruciates. One is for the anterior cruciate and the posterior cruciate. In the acute knee, we cannot do the anterior draft test because sometimes you cannot make the patient flex to 90 degree. Even we cannot do the pivot. It is very, very painful. The examiner will ask you in the acute knee, what test you can do? This is the Lachman test. The Lachman test is done classically with 15 to 20 degree of flexion. Why? Because this negates the doorstopper effect of the meniscus. So this is the way this can be done. If you can hold the limb with the sometimes the guy is big one, then you can support the thigh with your leg on the back side of the femur, or else if you can hold the femur properly this way, then you can do the Lachman. Big thigh or the big people when we cannot hold the femur, then we can do the Lachman in this supported manner so that my thigh will be under the femur and this will support hold this. Then we can do the Lachman. So when you do the Lachman you see the end point, whether it is a soft end point or the hard end point. If it is a soft end point or this way, then you can understand how much the tibia is coming in front, and always compare from the when you are asked in the exam to do. Never just do this the way on the injured limb. That the two things you remember in the exam, that you have to explain what you are going to do. then we do on the normal side, then you come to the injured side. This is the classic way of appearing in the exam. Then the anterior diatrist, how it is done. Always remember, sometimes they ask in the exam, what are the prerequisites, like the tenderer back, what is the prerequisite, what are the prerequisites for your anterior diatrist? Remember 4 points. One is that the hip has to be flexed to 45 degree, knee is flexed to 90 degree, the foot is fixed, and your hamstrings are relaxed. So these are the 4 points that you have to remember. So now you see the video, then you will understand how it is done. You see, I have kept the hip at 45 degree, knee at 90 degree, foot I am fixing. Better to sit on the foot. Then you always compare with the normal side. Then you come. You see that my index is palpating whether the hamstrings are relaxed, yes or no. Otherwise, you cannot test. You have to sit on the foot like this. Then you can check. Then you have to put your thumb beside the patellar tendon. Your palm of the thumb is basically feeling the front of the femur. Then the rest part of the thumb is checking how much of the tibia is coming in front in relation to the femoral condyle. So in the textbook, you may find like it 0 to 5, 5 to 10, more than 10. Then you can grade it like 1 to 3. And also you have to see the end point of it. If it is a soft end point, then if you compare with it the normal side, then you can understand whether there is any anterior cruciate injury, and always compare with the normal side. Otherwise, you cannot judge it. Then before I go into the rotatory instability, always this is the classic picture how you understand the rotate. I will explain that there are 4 types of rotatory instability that can happen. One is the anterolateral rotatory instability, anteromedial rotatory instability, posterolateral rotatory, and the posteromedial rotatory instability. I think the best to read from the Campbell, otherwise it is not very well understood. Because you see, the anteromedial structures, the anterolateral structures can be torn with the cruciates. And if we miss the posterolateral or the corner injuries, and if you just do your ACL reconstruction, if you don't do the corner injuries, this ACL or the PCL, whatever the best possible way you do, it is going to fail. So you have to understand what are the corner injuries which might be associated with your rotator, with your cruciate injuries. So this is the classic way of doing the pivot shift test. In the exam, sometimes the examiner asks you, where is the pivot and where is the shift? Always remember that when the intact ACL, the flexion extension of the pivot point, it is in the center of the knee. But when we do the pivot shift, that means pivot for a torn ACL, it shifts from the center to the MCL. So the prerequisite of having a pivot shift to be performed, you have to have a intact ACL. So this is the intact ACL. So pivot shifts from the center of the knee to the MCL. So this is the way how there are 3 components that you have to see in this video. Then you remember how the pivot shift is done.
Swarnendu, you mean intact?
See how I am holding the.
Swarnendu, you said intact ACL. It should be MCL.
Sir?
You said intact ACL. You meant MCL.
I told intact MCL.
Yeah, you said ACL there. Yeah.
No. Intact MCL is the mandatory because it sits from the center to the medial side. So it is gone to the medial side.
I understand that. It's okay.
Okay. If there is an ACL injury from the subluxated tibial position, it will reduce at more than nearly 30 to 40 degree of flexion. Why this is known as the pivot shift? Because your pivot from the center of the ACL knee, it is going to the MCL. So for a pivot shift to be positive, your MCL has to be intact. So this is the pivot is shifting from the center to the MCL. So this starts from extensor, and with interrotation and valgus, then you just gradually flex it. it will reduce. Because now your iliotibial band, which is going to the Jardis tuber, in 0 degree of extension, it is extensor. But when it at 30 degree of flexor, it becomes a flexor. So now it reduces the subluxated tibia into a reduced position. So probably now we have understood that the iliotibial band is the with the structure, which is basically when you internally rotate and you give a valgus force, basically tibia is subluxating in extension. So now when you gradually flex it to nearly 30 degree, then the iliotibial band becomes the flexor. So the subluxated tibia, now it comes into relocated position. So this is the iliotibial band is from extensor to flex, it is going to be flexor at 30 degree, and your pivot is shifting from the middle of your knee to the MCL. So MCL has to be intact to perform your pivot shift. Now you have probably seen the video, how it is, how I am holding the leg, because you see this is the way I am holding the foot. Interrogated and start in extension, give a valgus force, and gradually you just flex it. If there is an ACL injury from the subluxated tibial weight, you have to remember, you have to be very gentle in that. You cannot perform 3-4 times, otherwise the patient will be very, very apprehensive. And always tell the patient beforehand that he has to be very in relaxed position. Always explain this, what you are going to do. Try to do it and very gently on the normal side, then only you will be able to do the pivot shift. Because otherwise, in a very hefty guy, muscular patient, even with the torn ACL, you won't be able to perform your pivot shift, because sometimes it is extremely painful. This is known as the lateral pivot shift. This is a modification of the pivot shift, and this can be done even in a very heavy patient like this way. Also, this was the patient. This was explained by Shloka. You see, here the patient is in lateral position. So if the foot is like this, it starts in extension, and the upper torso is just rotated externally. And if you give a valgus force, so it is like the wrist pivot. And now from the extension, if you just flex it, so same thing is happening. The subluxated tibia will reduce. So this is the stroke of test. So this is much more comfortable for the patient, and this is much more easy to do it. And if you just if you read, this is very well described in the Campbell. Just read once, and I think you will be able to understand how it is done. The only thing is that foot is similarly. You see, if you just go ahead, I will run quickly. So the foot is just you have to rotate the upper torso to your side. You see, here the patient is in lateral position. So if the foot is like this, it starts in extension, and the upper torso is just rotated externally. And if you give a valgus force, so it is like the wrist pivot. And now from the extension, if you just flex it, so same thing is happening. The subluxated tibia will reduce. So this is the stroke of test. So now for the ACL, for the acute, we do the Lachman. For the chronic ACL, we do your pivot shift. We do first the anterior Dorad test, start from the normal side. Then for the PCL, you have to see, this is classically known as the sag side. You see, you have to see from the side, and if you compare both the sides, this is for the patellar tendon, this is looking like this. If you see from the side of the patient, like the silhouette vision, you see there is a posterior sag. So there is a posterior cruciate injury. Now you see how you see even you can see this tibia is gone back, and now you can check with your thumb, and if you reference with your femoral condyle, you check how much the tibia is coming in front. You see there is a wound at the front of the tibia. So this will give you the signal that there is a dashboard or the posterior sort of thrust injury, which will give you the trick that he might be having a posterior cruciate injury. So this is the your posterior drawer test. So posterior sag sign or the Godfrey test, how it is done. See this side. If there is a posterior sag, so then we can understand there is a PCL. The same thing we can do, like holding the foot like this and holding the hip and knee at 90-90 and seeing from the side whether there is a posterior sag. This is known as the Orthopaedic. Like this. Then another one is the quadricep active test. This is because we have to posterior make the patient relaxed. Relaxed patient, there is a posterior already sag is there, and if you ask the patient to just contract the quadriceps, because there is a posterior sag, once he tries to contract in 90-90 position, because of the pull of the quadriceps of the patellar tendon, the tibia will come front, which you can see from the side. So this is known as the quadriceps active test. Dial test. This is very, very important. I will tell once, then I will repeat it. Then this dial test is done in prone position. This is done for the posterior cruciate and also the posterolateral corner injuries. So just if you see it, this is known as the dial test. For the dial test, the patient will lie prone and we have to hold the foot like this. Okay. And at 30 degree, we will gradually externally rotate and see the difference from the foot. This is known as the dial from the foot side. So in 30 degree of flexion, you just check the external rotation of the foot. If there is difference of more than 10-15 degree on the injured side, you know that there is a posterolateral corner injury. So at 30 degree, if there is more than 15 degree of external rotation disparity of the injured leg, then we'll know that this is a PLC injury. Then similarly, same thing. So if there is external rotation on the injured side of 10-15 degree, 30 degree of pressure, we suspect the posterolateral corner injury. Then again, we'll do the same external rotation at 90 degree. If the external rotation increases, which was there at 30 degree, there is a combination of posterolateral corner injury and PCL injury. But if there was no increase at 30 degree, but there is increase of external at 90 degree, then this is PCL injury. So at 30 degree, if it is more external, it is for PLC. For 90 degree more external, it is for PCL. If from 30 degree to 90 degree, there is increase of both the external, then it's a combination of PCL and PLC. This is the dial test which is done. So I think probably I could explain it that if you see there is only increase of external at 30 degree, this is singular. There is no increase at 90, there is a singular PLC injury. If there is no external rotation, but it is increasing at 90 degree, then it is a PCL injury. If there is increase of 15 degree and it increases at again another 10-15 degree at 90 degree, then it is a combination of PCL and PLC injury. So in 30 degree external rotation, only PLC. 90 degree external rotation, PCL. If there is both 30 and 90 degree, there is increase at 90 degree external rotation, then it is a combination of PLC and PCL. So you have to remember like this. This is a very quick test. This is been described very long time. And this is for the known as the external rotation recurve vertebrum test. You just see it and then you remember. External rotation, just hold both the great toes and leave this in a relaxed position of the patient. And if we compare with the normal side to the injured side, if there is recurve vertebrum and external rotation of the injured side, then this tells us that there is a posterolateral corner injury. Recurve vertebrum and external rotation. So this external rotation and recurve vertebrum is this just hold both the great toes up. If there is recurve vertebrum and external rotation of your tibia, then you know this is the classically there is a posterolateral corner injuries. Then another one test you might be asked to is the reverse pivot shift. Why it is called reverse pivot shift? Because in pivot shifts we are internally rotating the foot or the leg. Here you see it is starting from the external rotation. And in pivot shift, we are starting from extension and then we go to flexion. Here we are just doing the reverse of it. You see the test, then I will explain it. If you see the reverse way, in pivot shift, we are internally rotating the leg. But here, you see, the foot is in external rotation. And but we get giving and foot is in external rotation and in flex. In pivot shift, we are starting in extension. But here there is two reverse. One is foot is in external rotation and it is in 80 degree to 90 degree of flexion. And then we give an axial load and gradually we extend. And if there is relocation, then we know that this is a posterolateral corner. So this is known as the reverse pivot shift because there is external rotation and it starts from flexion, not in extension. So this is again one test which we know this is classically done for the PLC or the posterolateral corner injuries. Then so we have what we have till now what we have done. One is we have varus and valgus at 0 and 20. We have done for the collaterals and the posteromedial or posterolateral corner. We have tested the posterior structures. Then we have done the joint line tenderness for the meniscus. Then we have done the McMurray's test, Applet grind test, Thessalian and Ege for the meniscus. Then we have done for the acute ACL, Lachman, chronic ACL, we have done the anterior drawer and your pivot shift test. For the PCL, we have seen this like the posterior sag or the Godfrey sign. Then we have done the posterior drawer test and the dial test we have done for both for the posterolateral corner and the PCL. And this is for also you have to test some because in the exam you can get the patellar injury cases where you have the recurrent or the post injury, the MPFL injuries you can have. So you have to test also the patellar stability. We'll be testing the MPFL or the medial sided injury. We have to test whether there is any tenderness on this side or the medial facet. Or from the history, we can diagnose whether there is something. And we can test the grind of this is the grinding of the patellar or the patellar scratch test so that we can see whether the patient is feeling any pain or there is any click or grinding sensation. And also we have to test how much of the patella is going with the force like this on the medial side. More than half of the patella should go to the medial side, otherwise there is lateral tightness. Another one is the patellar apprehension. If we push the patella to the lateral side and we see the face of the patient, if he is apprehensive, like the shoulder apprehension test, then there is injury on the medial side. This is the patellar apprehension test. Then I think we all know how to test the fluctuation test or the CD patellar tap test. Just for the sake of the exam purpose, you have to do. Then you keep the thumb and the index finger by the side of the patellar tendon and see the fluctuation with both the fingers. If you push from the index, feel with the thumb, then with the thumb with the index. When the fluid is more, then you can see you have to squeeze. Is whether the patella you can do the patellar tap. If the fluid is more than 60, 70 ml, then only probably you will get the patellar tap positive. So patellar J sign also you have to read how because sometimes you have to you can get the cases like in chronic knee cases like habitual dislocation or the recurrent dislocation. Habitual means every time it is going lateralwards. Recurrent means so like your recurrent dislocated shoulder. Sometimes it is dislocated. You can take from the history. And if you make the patient sit at the edge of the bed and you ask the patient how the patella is moving from flexion to extension, This is the classic patellar J sign. That means the patella moves from this there like a J from flexion to extension. It can happen in flex both the ways, but it goes in extension, like it goes lateralward. Then you know there is a injury to the MPFL, or from the history, from the tenderness. Then the classic J sign, you can know the injury to the medial side of the patellar structure or the MPFL injuries. So I think when we test the post-traumatic knee, the history is very important. Ask for when it hurts most, where is the pain, whether he is confident on his knee, whether he can do his day-to-day activities, whether during the climbing stairs up and down, whether there is any pain or not. Because sometimes the PCL, they will say only during coming down they feel pain, because this is the classic of the chronic PCL injury. So history is very important. Then you look and feel and do the special test in the classic stepwise fashion for the collaterals in 0 and 20. For the meniscus, you do the joint line tenderness and the apply and the McMurray. And for the ACL and PCL, I have already told you for the acute and the chronic situation, you see and do the test. And for the corner injuries, you do the dial test. And on the another one thing I forgot to tell you, that when you do the anterior drawer test, then also you can test the rotatory instability for the anteromedial and anterolateral. When you do the anterior drawer test, always if you do the foot, the anterior drawer in 30 degree of external rotation, then you will be testing the anteromedial side. And if you do the test in 15 degree of internal rotation, then you will be testing the anterolateral side. So this is the same anterior drawer. If you do in 30 degree of external rotation, you will test the anteromedial side, whether the tibia, the anteromedial tibia is coming in front. And in 15 degree of internal rotation, if you see the anterolateral tibia is coming in front, then you know this is the anterolateral structures are being injured along with the ACL. So we have tested the posteromedial structures, the posteromedial corner. You have tested the dial test is for the posterolateral corner. You know the anterior drawer test, and this is the rotatory instability for the anteromedial and anterolateral, which has been described by the Slocum. So always, if you go very systematic way, probably you will understand how to examine the traumatic knee injuries. And in the exam, you are not going to supposed to get the acute knee. You will definitely get the chronic cases, which might be ACL, meniscus, or the PCL or the corner injuries. So look, feel, move, and do this thing. Always at the end of the thing, you always measure the cuff and the girth of your thigh. So that is the end of your exam, because you have to, in the exam purpose, you have to see the wasting of the muscle is also very important. Always never forget to tell whether you have examined the spine, hip, neuro, and the distal pulsation. Thank you very much for this was the classic way of how you examine the post-traumatic knee, because I have not, because another class which we held in the same platform, how to examine the knee, that was with everything, what you like, from swelling to everything. But this, I think John sir directed only to tell me about how to go ahead with the stepwise fashion in a post-traumatic knee. So I have prepared accordingly. If I have forgot anything, I think John sir will add on. Thank you.
Thank you very much. That was a very clear exposition of the techniques of examination. So I'm sure all the people who attended it from the beginning would have benefited from it. If there are any questions, we'll take them now. I can't think offhand of anything that you've missed that is of real importance. I think you've gone through all the examinations very clearly. In fact, you've done a few which
Thank you, sir.
Are probably not done on a regular basis.
Yeah.
So, any questions?
Yeah,
Janki,
thank you very much, sir. Yes, sir. So, while waiting for the question, sir, one thing, sir, like sometimes in the short case, if we'll get this knee joint, there may be just 2 to 3 minutes to examine. So in that case, sir, uh, what all should be done? Like in 2 minutes, what all tests, including everything, sir?
No, I think in the DNB and exam, the DNB and the MS examiner, whenever me and Johnson is going, at least we are giving 10 minutes time for these hot cases. It is 2 minutes and 3 minutes it is complete injustice for the, even in we being expert also, in 2 minutes time we cannot examine the fully. But if the patient is giving history of instability, you just check for the, your three tests you do, the anterior drawer, Lachman, and the posterior drawer, you should not miss. And the dial test. And the mediolateral instability, varus and valgus, which can be done in 2-3 minutes. The collaterals, ACL and PCL, and the your joint line tenderness, and the McMurray. So these 5 tests can be done in 3 minutes. But I think 2-3 minutes for a short case, it not we are not going to, even being expert, we sometimes can miss many things.
So there was a question in the chat box about what exactly do you look for in the pivot shift?
Yes, this is a very good question. You have every time this has been asked in the exam also. Remember that word from the test, the pivot is shifting. Where is the pivot? Where is shifting? In an intact ACL, the pivot is at the center of the knee. But when the ACL is gone, if you see the structure or the anatomy of the ACL, it is coming from the center of the tibia to the lateral side. So when you are internally rotating the foot or the leg, and you are giving a valgus force at the near the fibular head, and you are in extension, that with the interrotation and valgus force, your tibia is subluxating. That means it is more internally rotating. It is not congruent with your femur. So now from the extended position, once you are flexing it, now your iliotibial tract, which is inserted at a Jardis tubercle at the front of the of your the axis or the coronal plane, when you come into flexion of 30°, now this becomes flexor. So in a subluxated position, your knee is now relocating. So now this iliotibial tract is basically relocating a subluxated tibia because of your internal rotation and valgus. Now it is coming to the, it is congruent with your femur. So this, from a subluxated tibia, you are basically reducing your tibia to your femur. So this is the logic of doing the pivot shift test. Am I clear, sir?
Yeah, very clear. I think that's should answer the question. There was a question about what if there's a bilateral tear? I think
bilateral tear means bilateral tear can happen like your ACL or the PCL is a rare injury. But always remember that how I have shown you the when you do the ACL, always remember your pulp of your thumb by the side of both the thumbs will be by the side of your patellar tendon. The pulp of the thumb will be feeling the front of the femur, and the rest of your finger is basically seeing how much is coming, how much of the tibia is coming in relation to the femur. So that is the point we even in the bilateral case, if it is coming more than 5-10 millimeter, you will understand this is having a bilateral. The bilateral, because you cannot be, because in a normal side we are not comparing. And the thing is that how it is ending. If it is ending in a soft end manner, then you know massy end point, then you know that it is a complete tear.
yeah, I think the only other thing is that in bilateral cases, you need to rule out ligamentous laxity or so you have to do all the other tests to make sure that the patient doesn't have lax joints.
Yes.
Okay, so that's
It is just like your shoulder examination. At the end of the procedure of any ligament or any joint test, you must, for your exam purpose, you have to see the Byton score system. If you some examiners are very particular about the Byton score.
okay. So thank you very much, Swarnendu. Great as always. And
Thank you, sir.
until we next time, bye everybody, and hopefully. Oh, sorry. There's another question.
Yeah.
So when is
No,
the FAT
there's
exam?
FAT exam this year. Okay,
And
this one. Maybe in the next month there is some internal assessment is there. For FAT, the date has not yet come. Okay, sir.
Okay, right. Thank you, everybody. And we should
Thank you.
close it there. Thank you very much. Okay, great.
Thank you, sir. Thank you, sir.
Thank you.
Welcome. Bye.
Thank you.
Bye-bye.
Thank you, sir.
Thank you, Janki. Everything went well.
Yes, sir. It's great, sir.
Yes, because I think last time, that's why I'm very particular that I will hold all the meeting from my home, because otherwise there is always a problem with the net.
Oh, maybe, sir. But this time there is no problem, sir. All the
Problem.
videos are
All the
quite
videos
good.
went well. Yeah.
Yes, sir. Went well, sir. Thank you,
I think
sir.
we are not been in the not been telecasted now. No, telecasted in the
Not sure,
problem.
sir. There because we may be, because Maharishi has not yet. It may be streaming still, sir.
Okay, so I
Maharishi
think
internet is also not working, so I
okay.
may end the meeting. Yes,
Okay,
sir.
I think the students, they have learned the most of the things we have covered.
Yes, sir. I think everything, sir, what you have